Hi, everyone. Thank you all for joining us for today's webinar, which is part of our webinar series funded by the Australian Government Department of Health, Disability and Ageing. And if you've joined us before, you'll know that what these webinars and webinar series are all about is how to apply evidence into practice, which is part of our comorbidity project. My name is Christina Morell. I'm an Associate Professor, Deputy Director of Treatment and Translation Research, and Program Lead of Treatment and Translation in Complex Populations at the Matilda Centre for Research in Mental Health and Substance Use at the University of Sydney, where I also lead the Comorbidity Project. And I'm joined by other members of the Comorbidity Project team today as we bring you today's webinar, which is being presented by Professor Lexine Stapinski. But before we get into that, I'd like to acknowledge and pay respects to the traditional owners of country on which we're meeting and recognise that we are joining from many traditional lands. The traditional owners of the lands that I'm currently on are the Gadigal and Wongal peoples of the Eora Nation, and I'd like to also recognise their continuing connection to land, waters and skies, and acknowledge the same for traditional owners of the lands that you're all joining from, and pay my respects to elders past, present and emerging, as well as any Aboriginal and Torres Strait Islander people who are joining us today. I'd also like to recognise and acknowledge the many people with lived and living experience of mental health conditions and substance use, as well as their families, carers, loved ones and chosen families, many of whom have been involved in our comorbidity project and the development of our resources over so many years. You'll all know by now to please use the Q&A buttons for any questions that you have for Lexine and the chat for any comments or anything other than questions for Lexine, which just helps us in the team keep track of what we pass on to Lexine, or whether there are any requests for support or technical issues that we need to help with. And yes, the recordings and handouts from today will be available from our website in the next few days or early next week. You can access our webinar library and also register for our next webinar at our website. And the link to do that is on screen, and we'll be posting that in the chat. If you have a few minutes at the end of the session, please, if you could take a moment to let us know if you have any feedback or suggestions for future webinars that you'd like to see as part of this series. And thank you to those of you who have been doing that after the past few webinars. We are making our way through that, and we do try to see what we can do to make this the best series it can be. And now it's my very great pleasure to introduce our presenter for today, Professor Lexine Stapinski. Lexine is a clinical psychologist, professor, and lead in intervention and implementation at the Matilda Centre. Her research focuses on improving early intervention and treatment for co-occurring anxiety and substance use disorders, and some of her contributions include developing the first integrated CBT program for co-occurring social anxiety and alcohol use disorders, and collaborating with youth to co-design a web-based early intervention for alcohol and alcohol misuse. Some of you may know that Lexine presented our very first webinar that we held as part of this series, which was a few years ago now. And even though that is still part of our library, we asked Lexine to come back and provide an update on the evidence, as well as some practical strategies on managing and treating co-occurring anxiety and substance use. So without any further faffery from me, I'm going to hand over to you, Lexine, to get us started when you're ready.
Awesome, thank you. And it was 2021, that first webinar, so 5 years ago now. And I'm pleased to say that is quite a bit to kind of update on since then. So a lot of work in this space, which is really nice. So I would also just like to acknowledge the traditional custodians of country throughout Australia. I'm presenting from Dharawal country, but I'd also like to pay my respects to the custodians of country where you are calling in from today, and any Aboriginal people on the call. And so the stuff that I'm going to talk about today, I'm going to start by just looking at the evidence about the link between anxiety and substance use, and I'll be talking about why it's important clinically, what we know about that. I'm also going to then talk about psychological treatment approaches that are effective for co-occurring anxiety and substance use. And just a caveat there that I'm a psychologist, as Chris introduced. So I'm going to be really focusing on psychological treatment approaches and not pharmacological treatment approaches, but I'll give you some resources at the end if you're interested in that. And then finally, we'll go into what does it actually look like in practice, integrating treatment approaches for this population. So jumping in though, so we're talking today about anxiety, a really normal human emotion that we all experience, particularly when you're delivering a webinar to a few hundred people. But we know at the other end of the continuum, anxiety can be a very disabling disorder with a huge impact on social work, functioning, and quality of life. And we've got data from our most recent national survey to tell us about how common anxiety disorders are. So this survey was conducted in the early 2020s among over 15,000 Australians. And what we're seeing is that 1 in 4 Australians are experiencing anxiety at that clinically significant level of interference. And the last time I presented this webinar, say back in 2021, in my introduction, I said 1 in 6 Australians. So you'll note there that we really are seeing an increase in anxiety over that period. And in fact, studies have looked at this increase and have estimated that we're seeing a 40% increase in the prevalence of anxiety disorders. So this is nationally that we're seeing that increase, but that aligns also with global trends that we're seeing where there's a rise in anxiety. So we can potentially have a conversation at the end about why that might be and what the implications are. But that's what we're seeing in the data. And when we're talking about anxiety, we're actually talking about 3 core components which all interact with each other. So we're looking to identify the physical sensations, the thoughts, and the behaviours that drive anxiety. And then in treatment, we're looking to apply strategies in each of these domains, which will help to reduce anxiety. So because of the way that these 3 components feed each other, the good news is that by applying strategies that target one of the areas, we can be affecting and improving the whole system. And the anxiety disorders that I'm going to be focusing on mostly are social anxiety disorder, so where we've got that core social threat, so the kind of worries people might have are around being maybe boring or unlikable or incompetent. We'll also be looking at panic disorder, so people that have that real physical threat might worry about heart attack or stroke or going crazy. And then generalized anxiety, so people that just have lots and lots of worries about lots of different things that might be worrying about meeting responsibilities, something going wrong, letting others down, and they might also have that kind of meta worry, worrying about their worry. So when we look at these disorders and how do they relate to substance use disorders, well, again, we can look at that national survey data that's been published recently. And what we see when we look at that is that, well, in Australia, over their life, about 19% of people will experience either an alcohol or a substance use disorder. And then for alcohol, if we look at risky levels, 31% will consume alcohol at risky levels. And when we look at how that links with the anxiety disorders, so we've got here in this table some correlations that are just showing us how often first of all, anxiety disorders, alcohol disorders, how often do alcohol use disorders co-occur with anxiety disorders? We're seeing correlations of around 0.3. So that's about a moderate association between the anxiety disorders and alcohol use disorders. And so in terms of the interpretation, so for example, if someone has an alcohol use disorder, there's about a 19% chance that they will also have a social anxiety disorder. So we're seeing it's pretty common among people with an alcohol use disorder that they may also have an anxiety disorder. And I've put down, just for interest, the rates for OCD and PTSD. You can see they're a little bit lower in terms of the correlations, but still a significant association there as well. So this is alcohol use disorders. What about drug use disorders? And what we're seeing here is a pretty similar relationship between substance use, drug use disorders and anxiety. But in some cases, we're seeing even higher correlations there. And I guess the picture here is that we're seeing quite a high proportion of people with a drug use disorder also have an anxiety disorder. So, for example, 43% of people with a drug use disorder have social anxiety and 22% have GAD. So an implication here is that if you have someone you're working with that has an alcohol or drug use disorder, there's a reasonable likelihood that they might have an anxiety disorder as well. So it's worth kind of exploring that and seeing whether that might be helpful. Okay, so how do we then understand this relationship between anxiety and substance use? Well, one model that has been proposed is that the anxiety disorder precedes and gives rise to the substance use disorder. And so this is the idea that alcohol and other substances may have either perceived or real anxiety-reducing benefits. And so people with anxiety disorders come to use these substances in an attempt to cope with their anxiety. And in support of this idea, we see that the onset of anxiety disorders typically precedes the onset of substance use disorders. And we also have some research evidence that coping motivated use, people, saying, I use substances to cope with anxiety, has been identified as a risk factor developmentally for substance use disorders. A second explanation is that substance use disorders may induce anxiety, so the other direction. And so, for example, when a person is withdrawing from alcohol, certainly we do see that there's an increase in anxiety symptoms. And so it's thought that prolonged use of substances may disrupt the stress response system and therefore contribute to anxiety. And so consistent with this idea, we do see that some anxiety problems do improve after a period of abstinence from substances. So certainly for GAD, there's some evidence that GAD will improve if a client has a period of abstinence from alcohol, their GAD will improve. Although it's estimated, because of the order of onset, so the fact that anxiety typically precedes substance use disorders, it's estimated that this explanation explains at most 25% of cases. And finally, we know that there are other genetic, socio-demographic or personality factors that may represent a common vulnerability for both disorders. So this might explain why they co-occur at a higher rate. And so in any case, once the problems begin, it's likely that they tend to fuel each other in a feed-forward cycle. And so this vicious cycle model put forward by Stewart and Conrad is one way that we can understand the relationship between anxiety and substance use problems. And from this framework, what we see is that the tendency to self-medicate with substances can lead over time to an increasing reliance on alcohol or other drugs to cope with anxiety, stress, or other negative emotions. And then this then leads to more substance use, increasing reliance on substance use to cope. And this in turn leads to more use. And as use increases, as more and more substances, the level of substance use increase, so does the range of potential problems related to substance use. So we see that substance use can then in turn exacerbate anxiety, both through withdrawal effects or through increasing the social, work, health, and legal problems for the person. And so we see a real kind of vicious feed-forward cycle that perpetuates both problems, keeps them going, makes them worse. And what we tend to see is that when people have both anxiety and substance use together, the problems tend to be more debilitating, they tend to be more chronic, and because of this vicious cycle where the problems are fueling each other, there tends to be an impact on recovery. Recovery is more difficult. So speaking of recovery, let's look now at what are the kind of treatment approaches that are effective for co-occurring anxiety and substance use. And there's 4 main types of treatment that have been evaluated for co-occurring anxiety and substance use. So this is the evidence that I'll talk you through. So the first treatments that we'll talk about are the standard single disorder approaches. So some studies have looked at the effectiveness of standard either anxiety-focused or standard substance use-focused treatments, and looked at how effective they are for people who have both anxiety and substance use. Secondly, a few studies have also looked at dual-focused treatments that are sequential. So this is when you either give the anxiety treatment first or you give the alcohol treatment first and then followed by the other treatment. And in this case, the treatment might be delivered by different clinicians and different services. Similar to that, we also see parallel dual-focused treatment. So this is when you have a separate anxiety treatment and a separate substance use treatment, but you're delivering them at the same time. And again, this might be delivered by different clinicians and different services. And then finally, we've got integrated treatments. And so these are the types of treatments where we're treating both the anxiety and the substance use, but we're doing it in an integrated way. So it's delivered by the same clinician and it's one integrated therapeutic package. So let's have a look at what's the evidence for each of these. And when we look at those treatments that are focused primarily on a single disorder, first of all, we do see some evidence that people with co-occurring anxiety and substance use don't benefit as much from standard substance use focused treatments. And some of the stuff we're seeing in the literature is that anxiety can interfere with engagement with those treatments. So particularly when you think about group-based treatments, you can see how anxiety might be a barrier to entering into treatment in the first place. But also we know that anxiety symptoms are among the strongest predictors of non-response to substance use treatments and also relapse to substance use after treatment. When we look at anxiety-focused treatments, the evidence is a little bit more mixed. There are some trials that have found that substance use didn't disrupt the benefits of anxiety treatment, that it worked just as well for people who had co-occurring problems. But a real problem here is that we only have really limited data because people with co-occurring substance use disorders are typically excluded from the trials of anxiety treatment. So we really have very little evidence to know how they tend to do in those treatment approaches. Okay, so looking now at dual-focused treatments, so treatments that target both the anxiety and the substance use. There's been a few trials of sequential treatments. So, for example, this one by Chardet, they showed that when you treated social anxiety and alcohol use disorder sequentially, you did see improved anxiety outcomes, but the substance use outcomes were basically the same compared to just focusing on alcohol. And then interestingly, when we look at parallel treatment, so this is when you've got two separate treatments that you're delivering at the same time, we actually see some evidence that this might be worse for people compared to just focusing on the substance use. So for example, this study by Randall and colleagues, they actually found that the alcohol outcomes were worse when they had this parallel dual-focused treatment compared to just treating the alcohol disorder only. And by way of explanation here, Randall et al. Thought that perhaps the worst outcomes might have been because drinking may have increased as a coping mechanism because clients were being encouraged to engage in exposure to feared social situations. And so that might have been why there was a corresponding increase in drinking. But these authors also discussed that the cognitive load of receiving two separate treatments from two separate clinicians might have been confusing or overwhelming. And I certainly think that makes sense as by way of explanation. So this brings us nicely to the case for integrating treatments. Because I think those previous two attempts, or the previous attempts to offer parallel unintegrated treatments, they might not be the best way to treat co-occurring anxiety and substance use disorders. And what you might see clinically is that people often report that these problems are interrelated. So given that they're seeing the interconnections between their anxiety and substance use, it might be beneficial to give people an integrated treatment approach that addresses both their anxiety and their substance use, as well as providing them with, support, explicit support about how to address the links that they're seeing between the problems. And providing an integrated treatment approach like this can also help to reduce the frustration that people might experience with typical treatments. So, for example, sometimes in treatment, clients are asked to stop or reduce their substance use before starting to work on their anxiety, which on some levels this might make sense because, we know there are cognitive effects of substances. The client might benefit more from anxiety treatment if they're not using as much. But the problem is if you're asking someone to cut back on their substance use, when that's their primary trigger, when anxiety is their primary trigger for using, that can be really difficult if you're not giving them the tools to help them manage their anxiety symptoms at the same time. So I guess also at the service level, integrated treatments can help to alleviate the frustration that clients can experience when they find themselves referred on from services due to their dual diagnosis. So I'm going to tell you now about some of the work that we led at my centre, so to evaluate an integrated treatment approach for co-occurring social anxiety and alcohol use disorders. And in order to develop the integrated treatment, our starting point was the current treatments that were supported for social anxiety and alcohol use disorders separately. But then when we were looking to develop the integrated treatment, what we wanted to do was have this repertoire of CBT skills that were then applied to address the person's social anxiety, to address their alcohol use disorder, and importantly, applying those skills also to help them address the interconnections between the two disorders. And so in our randomized controlled trial, what we wanted to do was ask whether that integrated treatment approach could improve outcomes for people who were diagnosed with both social anxiety and alcohol use disorder. And so those people in our trial, we had 117 people in our trial, and they were randomly allocated to receive either that integrated treatment approach that I showed you before, or alternatively, our controlled treatment approach. And the controlled treatment had the same skills. It still involved the same kind of CBT skills, the same motivational interviewing components. But in the control group, the comparison group, the treatment was focused only on addressing the alcohol use disorder. And treatment was delivered by the same clinical psychologist as the integrated treatment, and there was the same number of treatment sessions. So there was 10 treatment sessions in both conditions. And all of our participants in the trial also received a medical review, and they were given the option of pharmacotherapy if relevant as well. And so we saw in our trial that we had reasonable completion rates, so particularly in the integrated treatment, where 70% of the participants completed the treatment program. And to see how they did, to see whether the integrated treatment improved outcomes, we followed them up to see how they were going immediately after treatment, but also 3 months and 6 months after treatment had ended. So I'll show you now the results that we found. So first of all, we found that people in the integrated treatment group, so the integrated treatment is that blue line, and the control, the alcohol-focused treatment is the red line. And what you can see is that people in the integrated group had significantly greater reduction in their social anxiety symptoms, which is what we were expecting and hoping to see. And you can see that that was sustained over the entire period. So at 6-month follow-up, it was sustained. And when we look at their alcohol use and their alcohol dependence, what we saw was that both groups experienced a significant drop in their alcohol use and their alcohol dependent symptoms, but we didn't see any difference between these groups. Both groups experienced similar benefits. And this is interesting because in the integrated treatment group, the clients were being encouraged to reduce their social avoidance. So that group were attending more social events, they were going along to more activities, but they were managing to do this while at the same time reducing their drinking. So that tells me that they had been effective at developing other coping skills to manage their anxiety and to be able to apply that. And as you can see in this figure, those benefits were sustained at 6 months. We didn't see a relapse. And then finally, we looked also at broader outcomes, and we were pleased to see that providing the integrated treatment also improved people's overall quality of life. So things were going better for them in work, in their relationships, etc. And we also saw when we looked at depression that there were significant benefits of the integrated treatment compared to the alcohol-focused treatment for their levels of depression. And that finding appeared at the 6-month follow-up, where you see the orange and the blue lines are diverging there. So overall, the picture that we saw was that the integrated treatment approach offered improvements for people with co-occurring anxiety and substance use compared to the alcohol-focused treatment. And at the end of this session, I have the client workbooks and therapist workbooks that we used in this trial. So at the end of the webinar, I'm very happy to answer any questions about this program, but also share the links to those manuals if they might be useful in your practice. But so we wanted to also extend this work around integrated anxiety and alcohol treatment. And so what we did subsequently was adapt the program to provide an early intervention for young adults. And the idea here was that it would be a good idea to intervene a bit earlier in the course of these problems when symptoms are first emerging. So if we looked at that young adulthood period and tried to identify people then and help them to develop skills to manage their anxiety and drinking when they were first emerging in order to prevent escalation of these symptoms and prevent, those more chronic disorder level presentations. And so we adapted the program I showed you earlier to be a program called Inroads, which is a 5-week online program supported by a psychologist weekly support via telehealth. And we tested this program as well to see whether it would offer benefits in terms of improving outcomes for young people particularly. And so this was back in 2017 to 2019 that we run this trial to evaluate how effective the Inroads program was in reducing anxiety and drinking among young people compared to providing alcohol education only. So we had in this trial 123 young adults from across Australia. And what we found was that over a 6-month period, the Inroads program, so that's the group in green, they experienced significantly greater reductions in their anxiety symptoms, as well as their drinking behaviours compared to control. And what you can see in the control group there on the right is that there was this relapse to drinking among the control group. So they were able to improve their drinking initially, but then we saw that there was a relapse to drinking in that group. But in the Inroads group, we saw that they were able to sustain their drinking reductions. They were better able to do that. And I would say that's because they're being given those broader skills to help them also manage the anxiety that might be a trigger for drinking. And we received positive feedback about the program from the young people involved. And in terms of the size of the effects that we were seeing, we saw that on average, the young people in the Inroads program had reduced their drinking by 62 standard drinks per month, and they were having 4 fewer binge drinking episodes by the end of the program. And the next steps, I think, particularly from the experience of running the trial and continuing to work with young people, we're seeing really that, alcohol and anxiety often go together in this group, but also cannabis use and anxiety are often going together in this group. And so the next steps for us is we're working on adapting the program for co-occurring anxiety and cannabis use. So I'd love to hear also your thoughts about whether you think that's a good idea and that's something that you're seeing clinically. But so just to give you a bit of a summary of other research in this area, in addition to our trials, we're seeing, that there's growing evidence internationally to support integrated treatments for co-occurring anxiety and substance use. So there's been other trials that have looked at social anxiety treatments, and when social anxiety is co-occurring with alcohol, but also cannabis use. And both of those trials have shown, like us, that there were superior benefits in terms of social anxiety and also sometimes substance use outcomes for those integrated treatment approaches. And then other studies have also looked at OCD, panic disorder, and also PTSD. And also they've found superior effects on either anxiety and or substance use outcomes when comparing integrated treatments to substance-focused treatments. So there is a growing evidence base here. In addition, other trials have started to look also at transdiagnostic treatments, so looking at a treatment that's addressing transdiagnostic anxiety in the context of co-occurring alcohol, cannabis, or there's been one study that's looked at smoking as well. So as you can see here, there's slowly the number of trials testing integrated treatments has been building. And there's now actually enough of those trials out there that it's possible to kind of conduct a systematic review and synthesis of the findings to kind of look at the bigger picture in terms of what this means. So this is a review conducted just recently by Kate Wilitsky-Taylor in the US, and she looked at a meta-analysis of the effects from 11 trials, so combining the effects across 11 trials of integrated treatments. And from that, those authors concluded that integrated treatment outperformed substance use treatment. And the effect size that she was seeing, so it was a small to moderate effect in terms of how much better integrated treatment was than substance use treatment. I have noted, though, a few caveats, which is that this review wasn't comparing integrated treatment to anxiety treatment, and it didn't look at comparing integrated treatment to sequential or parallel treatment approaches, because there aren't enough studies to look at that. But just coming to the end of this section now, what can we conclude? We're seeing, when we look at the evidence, we're seeing that co-occurring anxiety can interfere with engagement and recovery from standard substance use treatments. When we look at anxiety treatments, there's limited evidence, but the evidence we do have suggests that people with co-occurring anxiety and substance use disorders may benefit from standard anxiety treatment. But on the other hand, integrated treatment might have greater benefits for patients for the same number of sessions. So you might be getting more bang for your buck if you're providing an integrated treatment approach. And I guess the bottom line, something that I think is really important, is that clients tend to tell you that they see their anxiety and substance use as interrelated. And I think that a benefit of integrated treatment is that it addresses that interconnection. So it has potentially a better alignment with people's lived experience. Okay, so how we're tracking for time. In the last part, what I'm going to do is kind of talk you through what does that actually look like in practice when you're applying integrated treatment. And I guess the first thing to say is the integration of treatment is going to occur at multiple levels. So first of all, we want to avoid that frustrating comorbidity roundabout situation that we often see for clients that have both substance and mental health disorders. So when we're integrating treatment, we're providing treatment for both anxiety and substance use by the same therapist and at the same service. So that in itself is important. But secondly, we also want to integrate the techniques that we're developing with clients. So rather than clients learning a different set of strategies to manage their substance use versus managing their anxiety, we want to help the client to develop one set of strategies and then understand how those strategies can be applied to manage both their anxiety and their substance use concerns. So I guess this avoids some of the confusion we might have seen in those previous studies where people had two separate treatments and were having to integrate it themselves. Rather than doing that, we as a therapist want to be doing the work of integrating and kind of helping clients to understand how they can apply one set of strategies to both problems. And then finally, it's really important to be actually addressing that interconnection between the anxiety and substance use. So the therapist is having explicit conversations with the client about that interconnection and how the client can apply strategies to address the interconnection between those two concerns. And I'll walk you through what an integrated approach could look like in practice and the key components. And for this, I'm drawing on the treatment that I presented earlier for anxiety and alcohol use, which has been applied in general samples, but as well as in young adult samples as an early intervention approach. And so the treatment approach that we applied was really embedded within a motivational framework. So the early treatment sessions are really focusing on identifying clients' own goals for change, forming a shared understanding between the client and the therapist of the problem, and really focusing on enhancing the client's reasons and own motivations to make changes. And as you're all working in substance use, I'm sure you know just how critical these components are. We know how powerful dependence is, and we know also that the people we're seeing in treatment they've tried before to reduce their substance use, and so they can feel that real lack of confidence that they'll be able to make changes. So having this overarching motivational framework is really important. It's something that we would revisit over the course of therapy. We really focus on it at the start, but we want to keep coming back here because of how important it is. It helps with anxiety as well. You know, you've got to have a lot of motivation too to kind of apply the strategies, do the work in terms of addressing anxiety. So having that motivational framework really helps for both problems. And because of this framework, it also means that the goals that we're setting for treatment are determined collaboratively rather than being imposed on the client. So this might mean that clients are choosing to reduce rather than to abstain from substance use. And that might be a decision that you revisit along the way to see how it's tracking, and you might need to calibrate goals along the way. A second important component is working with the client to build coping skills and to manage their triggers, both for anxiety and for drinking. And here they're really developing that repertoire of skills that they're then experimenting with to find out what works best for them. I really find in practice that the same skills will work very differently for different people. It's really about them finding the sweet spot in terms of what's working best for them. And we also wanting to enhance social support networks. This is really important for these presentations because we know that people can tend to be isolated, but we also see that often people might have existing social networks that are primarily drinking or drug using buddies, where the focus of the friendship is really around that substance use. So we want to focus on helping clients to reconnect or build sober friendships that do not revolve around substance use. And similarly, often, in addition to friendships, often activities and interests for the person have come to revolve around substance use as well. So we're also wanting to support the client to re-engage with other interests and potentially develop new interests. And given the client's anxiety, we also need to keep in mind that this might need to be done in a gradual way. We might need to be building up the client's skills to manage their anxiety to help them to kind of do that engagement with new activities and new interests. We're also working in the therapy process to help clients manage the thinking processes that contribute to both their anxiety and their drinking. So in the case of social anxiety, we see that people with social anxiety tend to expect negative consequences and outcomes in social situations. And so we would work with the client to critically identify and evaluate those cognitions and develop strategies to help them manage those thoughts. And the cognitive work that we would do would also include looking at the thinking processes that contribute to drinking and their alcohol use problems. So uncovering maybe some of the thinking that might drive the interrelationship between their anxiety and drinking. So for example, you often see positive beliefs that people might have about the function of alcohol. So for example, thoughts like alcohol makes me more interesting, or alcohol makes me perform better socially. So these are the types of cognitions that would be really important to work on for people with this co-occurring presentation. And people with social anxiety have over time come to avoid many different types of social situations. And so this next part of treatment encourages them to gradually reduce their avoidance and practice new coping strategies to manage their anxiety rather than using alcohol to manage these situations. So at first, clients might be encouraged to avoid cues that might trigger drinking, such as people or places. But over time, as the client gains confidence, we would encourage them to gradually build up their coping skills to handle these situations without alcohol. So a gradual process of building confidence to approach those situations is really important. And another component that's important is the focus of people's attention. So research tells us that people with anxiety are really, really sensitive and hypervigilant for any signs of threat. So in the case of anxiety, social anxiety, this means that people tend to be on the lookout for any cues or signs of negativity or judgment from other people. And being attentive to these signs does mean that one is more likely to notice negative feedback. If you're on the lookout for it, you're going to notice it, and this contributes to their anxiety. So by incorporating attention training, we can help to reduce this hypervigilance, and we can also provide a technique that might help people to disengage their attention and refocus from the kind of sticky, repetitive thought cycles that often contribute to anxiety and drinking. So we found this is quite an important component as well, particularly for some people. And finally, towards the end of treatment, we will be working with clients to make a plan for how they're going to continue change and how they're going to deal with any setbacks that arise. Okay, so I've done a lot of talking, but I did want to just quickly talk you through what it looks like in practice. So this is just two very brief case examples. They're amalgamations of different cases rather than representing an individual person. But I just wanted to show you a bit of a snapshot about what treatment might look like. So first of all, we've got Claire, who is in her early 40s with one daughter in a demanding professional job. She is very good at her job, but she also has very high standards and is very perfectionistic. And so Claire found that she enjoyed drinking as a way of escaping her stress and worries about work and after a winding down, after a frantic day at work. But over time, her drinking had increased to up to 1 to 2 bottles per day. And she found that she was experiencing some rebound effects of her drinking. She was embarrassed by her drinking in public situations, and she was worried about the impact on her daughter. And so a second little snapshot case is Luke, who's a young guy and is really, really nervous, particularly about speaking to women. So for Luke, he's starting to get a little bit hopeless. He's found a lot of his friends have started to settle down with partners, and he feels like he's quite left behind and feeling a bit hopeless about his prospects because of his social anxiety. And we also found with Luke that there were some beliefs that he couldn't talk to a woman without a drink. So he really tended to use drinking as a bit of a crutch. So would drink in advance of social events to manage his anxiety, but he would also drink at home because he felt hopeless and kind of depressed about the situation. So when we look at their motivation to change, but also looking at their kind of ambivalence around their use and some of the positives for them of their use, we saw with Claire that alcohol was really something she used to help her unwind. She also had sort of thoughts around, I deserve this, I deserve to relax, I've had a stressful day, I deserve this drink. But in terms of her motivations to change, she was really driven by those feelings of embarrassment and quite concerned about the impact of her drinking on her daughter. So that was a real prime motivator for Claire. For Luke, his reasons for use were to help him talk to women and feel more confident. But his reasons for wanting to change were that he was feeling like he didn't want to use alcohol as a crutch. And he also felt embarrassed. Sometimes he would have memory loss. He would then, particularly with his social anxiety, he would think, oh, what did I say? I can't really remember. So he would feel really embarrassed sometimes afterwards. So he saw that even though he was using alcohol at first to manage his anxiety, there were these after effects which were really making his anxiety worse. In terms of the critical aspects of treatment for each of these clients, so for Claire, a big thing was getting her out of her evening routine of pouring a glass of wine as soon as she walked through the door. So drink replacement was a really positive thing for Claire. Replacing with a sparkling mineral water drink helped initially, but she also made an effort to kind of introduce other activities, so doing other things in the evening instead to help her get through without drinking. And the cognitive therapy component was very important for her to challenge both her cognitions driving her anxiety, but also those positive beliefs that she had about alcohol, that it helped her relax, and also the drinking thinking around, I deserve this. So we had to do a lot of work around those cognitions to help her in reducing her alcohol. And I guess what helped there was her starting to get a more realistic picture, really starting to see the impact that her alcohol had on her anxiety. So she was kind of getting that feedback that actually her alcohol wasn't helping her anxiety at all. She could see once she started to reduce her alcohol use that she was more motivated, that she was able to get more organized in the evenings, and she was also less irritable and stressed the next day, which meant she was less worried about her daughter and the impact that Claire's drinking had on her daughter. And then Luke, for Luke, an important strategy was he found that if he didn't buy alcohol, he wasn't inclined to leave the house once he got home. So that was an important one to reduce his drinking at home. We also focused on building up his confidence in social situations using a combination of behavioural experiments and cognitive therapy. And it was important to challenge his belief that alcohol helped him to talk to women by actually examining the evidence critically. And when we did that, it was obvious that, the effects of alcohol weren't actually helping him in his interactions with women. He had the memory loss. He wasn't always behaving, as he would like when he was drinking. So he could really see that it actually wasn't helping him. It was really hurting those interactions. And he also started over time with increasing confidence. He started to test out through behavioral experiments his belief that he couldn't interact with women without drinking. So he started to attempt those interactions while sober, and this increased his confidence as time went on, starting from easier targets at first, and then building up to talking to more and more women. Okay, so coming to the end now, I just wanted to touch on some of the common challenges that we see along the way. It's important to be assessing for risk of complicated or severe withdrawal from substances, and often working in partnership with a medical provider can be really useful for providing support here. We also know that motivation is fluctuating. There's that ambivalence that fluctuates over time. So this needs to be revisited. And this is true for substance use, but it's also true for anxiety. So really keeping motivation central to the treatment is important. We know, of course, that there are sometimes cultural, social, or cognitive barriers that we need to consider with treatment. When we're talking cognitive barriers, sometimes the treatment might need to be simplified. There might be effects of substance use on the person's functioning. So you might need to simplify or just go a lot slower with people. And then finally, shame and stigma is, of course, an enormous issue. It can really, impact on how our clients are reporting their week to you, and it can result in dropping out of treatment as well if they're trying to avoid, talking about their disappointments or their lapses. So it's really good to anticipate this and have some explicit conversations at the start of therapy to say, look, there are going to be challenges and disappointments along the way, but I really want you to come and talk to me when that does happen, so that we can learn what got in the way, and we can learn how to approach things differently next time. Okay, so I said I would share some other resources. So if you're interested in learning more about the Integrated Social Anxiety and Alcohol Use Program, we've got a number of papers that describe the program in detail, but also we have on the Open Science Framework, you can access the client workbooks and the client therapist guides for free. So we'll give you the links so that you can access those right now if they're useful to you. But then, of course, not everyone's treating social anxiety and alcohol use. So if you're looking at integrated treatments for anxiety and substance use more broadly, I would recommend this book, Treating Comorbid Substance Use and Emotional Disorders. We have one chapter in there on social anxiety, but there's lots of different chapters that cover a whole range of different anxiety and a whole range of different substances. And also the Clinical Guide to Exposure Therapy. There's a chapter in there that talks specifically about how to do exposure therapy for clients with substance use disorders. So in the slides, hopefully all these links will work well for you, and you'll have all of those resources. But I also just wanted to plug for the comorbidity guidelines. I know you all know about it already, but that's a resource where you can find all sorts of information about different anxiety and substance use treatments more broadly. So that's it for me. I haven't left a lot of time for questions. Sorry, Chris, but a little bit at least, just to thank my collaborators and my funders as well. And thank you all for listening. And I really look forward to the questions and discussion.
Thank you so much, Lexine. That was amazing. We don't have a lot of time for questions, but we do have a lot of questions. So maybe we'll try and do things a little bit differently. And if you're happy, Lexine, to stay on for a couple of minutes, we might go through a few questions and then close out, which is just a little bit different to how we normally do things. So I know people are leaving, but if you have time or if you've asked a question, maybe you can have a look back at this recording and find your question answered, which will be a nice surprise for you later.
And go to the books. The books will
That's
maybe
right.
answer all the questions.
A question from Belinda. If a client had social anxiety disorder and PTSD, the percentage of drug and alcohol issues would be both added together to indicate the increase in likelihood. I think this was relating to the ANZJP comorbidity paper that you had up
Yeah.
earlier.
Mm-hmm. So, so the question is whether you just add the percentages to a
Mm,
yeah, it's not quite as simple as that because of course what we know is that anxiety disorders are also co-occurring. So if you have social anxiety, you're also more likely to have PTSD. So that the analysis that I showed you was really just trying to look at like single anxiety disorders and the probability. So it wouldn't be as simple as just adding it up, but you're right in the assumption that you'd have even more likelihood of a
mm,
substance use disorder if you had both social anxiety and PTSD. Yeah.
mm. Thanks. Okay. Who should or who does make the decision to use integrated treatment, and what does the RAN, RANZCP say about it? If
Mm,
anything, and as a consumer, it's almost impossible to direct the treatment model.
interesting. Look, that's a great question. So the guidelines, I mean, the comorbidity guidelines are a great source of, in terms of what do the current guidelines say. And as I hope I've explained, this is like an area where the evidence is increasing. It's been taking some time, but I would say like over the last 20 years, we're really increasing the evidence. My view is we now have like stronger evidence to say integrated treatment's a good idea, and the guidelines are updating kind of,
Mm,
in line with the evidence, but it's different for different anxiety disorders. So there's more evidence for social anxiety because there's been more trials compared to other disorders. Um, your question about as a consumer, how do you that you don't have power, I think was the point. And I would say, look, I think as a consumer, you should be having a discussion, about your treatment. As the framework that we work from is very collaborative in terms of you'd have a discussion with your client and say, look, this is what I would recommend for treatment, but you would be wanting some feedback in terms of that. So I think as a
mm,
consumer, you can advocate. You can say, I think that my substance use is really linked to my anxiety, and I'd like to work on both at the same time because I think that's the way that I would most benefit from treatment. So I would encourage you to do that. And often for clinicians, the barrier might be a lack of resources or training, which, initiatives like the comorbidity guidelines are really helping to address that by providing that support and training as well.
a lot of shout out. Thanks, Lexi. Um, I do remember looking into that when we did the comorbidity
Mm.
guidelines, Tony, and I don't have that link on hand at the moment, but perhaps someone from the team could just pop that chapter in the chat. It's a couple of years out of date, but there should be some resources in there that might be able to help.
Talking of great
Oh, you're
programs,
here.
Lex, I'm back. Sorry. Talking of great programs, there's quite a few people very interested in the Inroads program, Lex, and
Mm.
wondering, is it still being used in the community? And where it is being used, or when it was used, is there sort of a way that clinicians can track progress through if they're using it with a
Mm.
client?
Yeah, that's very cool. So at the moment, we've just finished a second trial of the program. So it's currently in follow-up from that second trial. But what we're hoping to do is to, once we have the results through, is to then disseminate more widely and integrate. And I think it would be great to integrate with services because I think that combination, I didn't get time to explain too much about the online component, but we wanted the online component because, young people really like online. It also makes it really accessible, at all hours of day and, in all areas of the country as well. So I think there'd be really good advantages of combining that online support with clinicians working in the field. We haven't made that work yet, just because we're not there yet. But if you have ideas about how that could work, I'd really love to. Got my email. Oh, I stopped sharing. But yeah, the slides and my email address, because I'd love to hear how you think that would work in your service. In terms of the tracking idea, we don't currently have tracking for clinicians, but that could be something that we could integrate. It's a great idea.
Thank you. Somebody, I'm not sure who asked this question, but somebody's asking if you're considering or if there are any specific studies focusing on anxiety and substance use among young people experiencing homelessness.
Another great question. So I would say that the research area in terms of integrated treatments is really just building at the moment. So I'm pretty sure there are no studies that have looked specifically among homelessness, because there's only a handful of studies that have looked, at all. But it's certainly something that, in fact, you had a previous webinar on this, didn't you? I know Dr. Marley Bauer presented one on homelessness, and maybe that was more on social connection and homelessness, but she would be a great person to kind of look up. But I would say no, there isn't currently evidence on that. I would be pretty confident in that, because there's just little evidence in general about integrated treatment. But I don't see why you couldn't apply these kind of models, with the benefits of having a clinician to adapt and customize. I think you could apply these models in different populations.
Thanks, Lex. We might have to hit Marley up again. Sally is asking about, under the integrated treatment program, if there are any group-based approaches, and if so, how this works with people with, for example, complex PTSD.
So by group-based approaches, do you mean like a group treatment delivery, do you think? I know it's not your question, Sally.
Yeah, I guess she's asking if it's individual or group-based, and thinking about the large number of clients with the anxiety or the complex post-traumatic stress syndrome. How does that I guess she's asking the group part of it work? Is it appropriate?
Okay. Well, so sorry, I should have explained that. The treatment trial that I talked about was individually delivered. I think in the context of social anxiety, when I've worked in social anxiety delivery in general, groups are fantastic, because you're combining, exposure and developing skills, every week when you go to therapy, just, being in the group. So there are real advantages there. But I guess with the integrated treatment, because of the need to really focus on motivation, to kind of provide that like tailored, customized support, we chose an individual model for treatment. And maybe that would be a similar kind of answer in terms of complex PTSD as well, that you would, I could see some challenges doing that in a group setting, because of the way you might need to kind of really work individually with a person, understand how their problem fits together. I mean, I presented kind of two little mini cases here, but there's just so many different ways that people's substance use and their anxiety goes together or feeds each other, and they're quite different, they're quite unique. So I do find it helpful to be working individually, although, I think there could be benefits of the group setting as well. Maybe both. Maybe you do like some group, a bit like the DBT model, some group-based skills as well as some individual sessions. Yeah.
Thank you. I've got somebody here, Gina, asking specifically about those case studies. So when we were talking about Claire, and she was shifting, decreasing her alcohol use and swapping it out for fizzy water, I think you said. How was that done? Did it involve a detox or supported reduction? And was there any pharmacotherapy involved in there as well?
Yes. So the cases are amalgamated cases rather than specific people, so I can't just think back in my brain. But I think in general, we were really careful, particularly with alcohol. So it's a great point. With alcohol, you want to be really careful about withdrawal. So all of the clients that we had would have a medical review at the start of treatment to kind of determine whether it was something that was safe for them to proceed with without kind of assisted supervised withdrawal. And so some cases people did have to be referred for supervised withdrawal, whether that was at home or inpatient. And then they could come back to our program. So it wasn't that they couldn't do the program, but they just needed to have that support in place first. But in the case of Claire, it wasn't necessary. In that case, a supervised withdrawal. And so in terms of the drink replacement, it's a case of sometimes people are tapering, or sometimes people, it's just recommended they are, safe to reduce. Yeah. But I have to say about drink replacement that it's such a simple strategy, but it was one that I found surprisingly useful for so many people, because they've just got that like association, that habit of, I come home, I drink, I get this glass every day. And so just the developing, instead of, I always say, if you're going to take out something that's been really useful to you, you've got to put something else back in. You can't take out a positive without putting back in a positive, because then you just, yuck. You just got more negative in your life. So yeah, for clients like that, putting in a positive alternative drink that they could use instead, building a new habit, really worked well.
Nice, thank you. I've got a few here, Lex. If you're okay to stay, this is so useful for us.
Yeah.
Miriam's asking about severe substance use disorder. She's wondering how appropriate integrative treatment is, or whether we have any studies on that. She's just said severe substance. I'm not sure what you're thinking about specifically, Miriam, but what are your thoughts on that, Lex?
So I'll tell you what data that I do have first of all. So in our trial, we thought that we might see a moderation by severity. So we thought that what we might see is that integrative was better for people with low alcohol use severity, and that just focusing on your alcohol might be better for people with high alcohol use severity. Because it might be, if you're really severe, you kind of just have to focus there. It's not a good idea to divide your attention. So we had a look at that, and we actually found no evidence. So the integrated treatment was equally beneficial whether you were severe or you were less severe. So, and we had quite a spectrum from really lower levels to quite severe alcohol disorder clients as well. So that's in the case of alcohol. In terms of other substances, the Cass-Mills COPE treatment, which is for co-occurring substance use and PTSD, I know in that therapy they've looked at a whole range of different substances. I don't think they've looked at it by severity though. I don't know, do you know the answer to that, Chris? No, but they've certainly looked at different. So if you're talking about whether there's some substances that are just too severe for an integrated approach, I think we can draw there on the COPE literature, which tells us that, actually many different substances would benefit from an integrated approach. Yeah.
Great. We have a great one here because it's about a case study that someone's obviously working with somebody about. So I'd love to read you this one. Somebody says, hi, I have a client who stopped drinking and is in maintenance for the last 6 months. Client's being diagnosed with borderline personality disorder and anxiety. Recently told me they had urges to drink due to feeling not enough and low self-esteem. Drinking had helped numb these feelings before. We've been working on her with urge surfing skills and also building self-esteem and discussing harm reduction strategies for coping. Anything else that you could advise that might help with this client?
I think what you're doing sounds fantastic. Like, you've got such a clear formulation of like why they were drinking, why it's hard for them to stop, and you're applying things to kind of address, those mechanisms that you're seeing. I guess the other things I'd be thinking of, you've already said you're working on building self-esteem, but maybe that idea around, like, we called it developing alternative reinforcers, so like looking at, again, it's that, like, don't take out a positive without putting a positive back in. So for this person, are there things that they can, as they increase in their self-esteem and their confidence, are there things that they can put into their life that really enhance it and make it enjoyable? So whether those are new activities that they haven't tried before or new friendships, the social support component is so key as well. Often people have really impoverished relationships, so they might have to go back and go, like, are there relationships from my past that I can, people I can reconnect with, or new relationships that I can form that really just enhance my current life and make me not feel like I need to drink to numb things. But look, it sounds like you are doing, you're on the right track with what you've described. Yeah.
Great, thank you. Lex, somebody has asked about sleeping when reducing AOD. Are there things to help? They've specifically asked about CBD oil, sleeping tablets. Is there ever evidence that we know that really helps people specifically with sleeping when they're reducing their substance use?
Yeah, so sleeping I didn't talk much about sleep, but it's a really important one. It's important in terms of some of the reasons for use. I mean, I find particularly with alcohol, but also obviously with cannabis, it's a really strong reason that people can be using sometimes. But also with the vicious cycle nature of things, you can also see that is negatively impacting their sleep and definitely negatively impacting their function. I think one thing that I will mention here is there's been a recent review coming out of our centre that just looked at the effectiveness of cannabis. He's smiling, Chris. We can put the link in perhaps. So there's been a large systematic review that looked at the effectiveness of medicinal cannabis for a whole range of different presentations. What they found in that review was that there wasn't good evidence when you synthesize the literature internationally. There wasn't good evidence for anxiety. So not good evidence that medicinal cannabis is helpful for anxiety. I can't remember about sleep. I think maybe you have it in front of you. Chris is going to put it in the chat and then you can look it up yourself. Yeah.
We have a talk on this paper this afternoon, don't we? So we can get the answer and post it in the community of practice.
Amazing. It might have, yeah, I don't want to say when I can't really remember.
Thank you, Lex. Let's move to this one because this is a great specific question from Gemma. Can you please share the specific technique used for attention training when you're looking at the hypervigilance?
I would love to share the manuals. So I'm very excited because these manuals we just updated the graphic design in the manuals. I managed to do that in time for today's
amazing.
Today's webinar, which was good. So because it was so outdated. If you had downloaded the old ones, they looked like they were made in the 80s, and they weren't made in the 80s, but they looked like that. So I think the best answer to that question is to have a look at the manuals, because in the manuals we have the exact techniques, the therapist guide and also the client workbook for those techniques. I can put them in the chat, or has someone already? You probably don't have the link.
Did you say that you had them in the slides?
They are in the slides, yeah. So they'll go around to everyone, but I can also put it in the chat so you can download them right now.
Amazing.
Yeah, if someone just talks while I do that.
Thank you. Well,
thank you.
I'll find a link.
And maybe we might have to wrap it up so you can move on with your day, Lexine, because I know we've kept you way over time. And I know that we haven't got to everybody's questions either, and I'm sorry about that. But I will just wrap up quickly and say that you can also find out more information about our guidelines, which this webinar series is linked to, and our other resources at our website there on screen, including our newly released implementation toolkit, which are all free. And for you practitioners out there, I will mention again that our online community of practice, which is funded by the Australian Government Department of Health, Disability and Ageing, is available, which is for professionals in Australia who work with people experiencing co-occurring alcohol and other drug use and mental health conditions. It's also free, and you can find out more by navigating to our guidelines homepage, or the link is on screen there. And I wanted to thank you all again for having joined us, and especially to those who've stuck around to hear these questions, and especially Lexine for having stuck around for us to extract more information from your brain than we initially asked you. If you're interested in having a look at our library of past webinars, watching this one again, catching up on anything that you might have missed or sharing it with your colleagues, you can do this at our website. We're still finalizing the title for our next webinar, but it will be on the 4th of June with Professor Vanessa Cobham, and she has so much to talk about with us, but we think it will be likely something focusing on young people and trauma. But you should be able to register for that now, or at least later today, with the title to be confirmed shortly. And until then, thank you again for joining us today. Thank you again so much, Lexine, and please enjoy the rest of your day, everyone.